So, thank you. We have already heard something about rotational osteotomies from Vicente. And the thing is that this biomechanic, as Vicente told us, is that there are increased forces laterally when you have increased femoral anteversion and tendency towards subluxation or luxation and increased tension on the MPFL. In this study, they compared two groups of patients having patellar instability and the control group. And what they found was that in the instability group, there was higher degrees of femoral anteversion compared to the control group. So, shall we ever consider to do concomitantly bony surgery when we do MPFL reconstruction? Why not just do the MPFL reconstruction? Sometimes the patella will stay stable, but the patient will not become symptom-free. And the thing is that we should also look upon the scores, the patellofemoral scores for the patient. It's not enough that the patient gets stable, they should also have a good knee and they should be able to return to sports. So sometimes there are indications for bony corrections, and it could be femoral or tibial derotational osteotomies. If you look at the failure studies of MPFL reconstructions, what they say is that it's in most cases either wrong femoral insertion site or trochlear dysplasia. However, there are now studies out there saying that it is also related to increased femoral anteversion or tibial torsion. There is this meta-analysis with 8 studies looking at the result of derotational osteotomy for patellar instability, not anterior knee pain, but patellar instability. And they saw no subluxation or luxation after this. So this is what we're talking about. Vicente mentioned that, squinting patella, inward pointing knee, and increased femoral anteversion and increased tibial external torsion. And this woman here, she had some degree of trochlear dysplasia. However, I only did rotational osteotomies and she performed very good. You also call this torsional malalignment or mesomolar malalignment or tetotorsional malalignment. And the thing is that these patients, they walk like a dog. We already saw that. So the thing is, increased tibial torsion, it hasn't been studied that much how much it relates to patellar instability. So there is a lack of evidence. However, there is studies demonstrating that increased TTGG is related to increased tibial torsion, and increased tibial torsion the other group. So this recent study from US by Lee-Pace, they have unpacked the TTGG distance. The TTGG distance has been so much overused. And you have to realize that the TTG changed very much from one MRI scan to another. So if you have a patient who have 2 MRI scans, try to measure the TTG and you will see how much difference there is. However, if the TTG increased, it's either due to medialization of the trochlear groove or increased tibial external torsion. Rarely it's the lateralization of the tibial tubercle. So how common is torsional abnormalities? According to this study, it's actually seen in 15% of patellar instabilities. So who will need this rotational osteotomy? I mean, if we see patients like those Vicente showed that they were walking like a dog, and they have clearly inward pointing patella, that there is no discussion, they will need derotational osteotomies. However, if there are no obvious reasons for patellar instability, if there's no dysplasia, if there's no patella alta, if there's no valgus, try to do a rotational profile of the patient, but then you will see that you overlook this condition again and again. And you shall look for the winking sign, I will show you, and you can do a clinical examination, and this might indicate a torsional problem. This is a winking sign. You have seen it many times, or at least it has seen you many times, but you haven't perhaps not been aware that if you have this overlap, it is likely due to a rotational problem. You can examine with the Staheli method. I will say in my hands, it's not very precise measure. I don't know, maybe I'm not good at it. If it's obvious, it's easy to see, but in many cases, it's when I do the CT or MRI, I realize that there are increased femoral introversion. And similar with the tibial torsion, you can use this second toe test, or you can ask the patient to put the patella in front as the picture on the left, and you will notice that something is clearly strange. So this has huge importance. If you measure CT or measure the torsion with the CT or MRI, you have to say which method you have used. It's not enough saying that the patient has 25 degrees of femoral antitorsion, because it is very different from method to method. The method I use is the Weidelich method, and it's the center of the femoral head and the center of the trochanter. On the tibia, I use the Ulm method. And surgically, what I use is the Hinter-Wimmert method. It's a biplanar where you take out a small wedge laterally, and then you derotate according to how you have placed your Steinmann pins. You put the Steinmann pins before you do the osteotomy, and then you just make them parallel, and then you will have the right angle. However, I look forward to Andreas Imhoff, who is going to tell us of a new method I'm not aware about. It is not easy surgery. And derotational osteotomy, depending on which mood I'm in, I do it medially or laterally, as you see here. This case is a little crazy case. I operated her Wednesday, and she has, as you can see, severe femoral anteversion, 60 degrees with the Weidelich method. She has also trochlear dysplasia and patella alta. And what I did was, I started out with an arthroscopic trochleoplasty, as you see on the right. And then I did a distalization of the tibial tubercle. And as you can see, I did a derotational osteotomy afterwards, like here. And then I did an MPFL reconstruction. And since it's only a week since I operated her, I don't know the condition of her. So the take-home message is, if there's something you cannot explain by your examination, please do CT or MRI of hip, knee, and ankle and measure the femoral torsion and tibial torsion. Thank you.